Welcome back, guys, to the fourth video in the CVS Pharma playlist. Today's topic is diuretics. It's a small topic, so let's get started. First, we're going to look at drugs and sites of action. So, इसमें पहला है carbonic anhydrase inhibitors. इनका site of action है PCT, as you can see, proximal convoluted tubule. फिर next आता है loop diuretics. अब उसके नाम से पता चल रहा है कि ये loop of Henle में act करेगा, तो and it acts in the ascending part of the loop of Henle. फिर आता है thiazides. They act in the early distal convoluted tubule, and then come potassium sparing diuretics. They act on the collecting tubules. एक और भी है इसमें जो कि osmotic diuretics हैं, वो overall act करते हैं, and I'll discuss this at the end of this lecture. So we're going to discuss carbonic anhydrase inhibitors first. Before we look into the drugs, हमें उसका mechanism of action पता होना चाहिए. तो इधर एक diagram नजर आ रहा है जो कि काफी complicated लग रहा है, but it's not really complicated once we understand what's going on. So we will break it down. जो carbonic anhydrase inhibitors हैं वो prevent करते हैं reabsorption of bicarbonate ions in the proximal convoluted tubule. तो इसमें यही दिखा रहा है कि जो hydrogen ions हैं they combine with the bicarbonate ions in the tubular fluid. This is the tubular side where the urine is forming, and this is the interstitium blood side where things are getting reabsorbed into the blood. So hydrogen ions in the tubular fluid combine with bicarbonate ions to produce carbonic acid, which is then dehydrated by carbonic anhydrase over here to water and carbon dioxide. फिर ये carbon dioxide diffuse कर जाती है into the tubular cell, और ये वापस convert हो जाती है into carbonic acid by again the carbonic anhydrase, और ये break up होती है into hydrogen ion and bicarbonate ions. अब ये जो hydrogen ion है, it goes through the sodium hydrogen exchanger, जिसमें hydrogen ions फिर बाहर निकल आते हैं और जो sodium है वो अंदर की तरफ आ जाती है. Then the bicarbonate ions are absorbed into the blood. Now these carbonic anhydrase inhibitors inhibit carbonic anhydrase. So over here, carbonic anhydrase gets inhibited, which results in the retention of bicarbonate ions. They don't get absorbed into the blood, and hence they get excreted out, and which in turn there is no sodium and hydrogen exchange. So less sodium gets absorbed, and sodium also gets excreted out into the urine along with bicarbonate ions, and this results in diuresis. And because bicarbonate ions are a great component in the buffer system, so when there is no bicarbonate in the blood, the pH will decrease and it will be more acidic, and it will result in metabolic acidosis. Now this results in mild diuresis because this is only in the proximal convoluted tubule, and sodium still gets absorbed in other parts of the nephron. Now some key points regarding carbonic anhydrase inhibitors. Acetazolamide is used in glaucoma to reduce intraocular pressure and in acute mountain sickness. Acute mountain sickness is because of the low levels of oxygen at high altitudes. It also causes hypokalemia and metabolic acidosis, as I've explained, and it shouldn't be used in patients with liver disease and COPD. Now moving on to loop diuretics. The drugs included in this group are furosemide, bumetanide, torsemide, and ethacrynic acid. Now again, we have to know the mechanism of action. So we're going to take a closer look at what's going on in the tubular cell. So most of the sodium gets absorbed in the ascending limb of loop of Henle, about 25%. So these loop diuretics are powerful diuretics. So sodium enters the cell through this co-transporter, which is the sodium potassium 2Cl transporter. And as sodium enters over here, it also exchanges potassium. And this potassium goes out towards the tubular fluid through potassium channels over here. This causes a more positive charge in the lumen, and to balance out this positive charge, calcium and magnesium follow through paracellular route. and gets absorbed into the blood. So when loop diuretics inhibit this co-transporter, then we lose chloride, sodium, potassium, calcium, and magnesium, all of these ions. So when we lose all of these ions, obviously there would be side effects related to these ions that we're going to see in the next slide. अब हम side effects पे आ जाते हैं. तो जैसे मैंने कहा कि we lose all these ions. So first, looking at calcium and magnesium, when we lose them, it leads to hypocalcemia and hypomagnesemia. We also lose potassium, so that leads to hypokalemia, but that can be treated by giving it with potassium sparing agents. Then hyponatremia, obviously because we're losing sodium. Ethacronic acid and furosemide compete with uric acid, and this causes hyperuricemia, and which aggravates gout. It also causes hyperglycemia and hyperlipidemia. And another important side effect that we must know is ototoxicity, because the sodium, potassium, and calcium co-transporter also exists in the ear. So blocking of this causes ototoxicity. Furosemide and thiazides also lead to toxicity of digoxin and lithium. Now moving on to thiazides. They act on the early distal convoluted tubule by inhibiting the sodium and chloride co-transporter. So sodium and chloride gets absorbed into the early distal tubule cells, and sodium exchanges with potassium and chloride just gets absorbed through the chloride channels. But when this import gets blocked, then we lose sodium along with chloride. Thiazides also cause similar side effects to loop diuretics, except they cause hypercalcemia and hypokalemia. Hypercalcemia because there is so much negativity in the lumen that calcium ions get paracellularly absorbed into the interstitium. Thiazides are longer acting drugs than loop diuretics. They may also cause impotence, so they are not used to treat hypertension in young males. Metolazone and chlorthalidone are thiazide-like drugs. Their mechanism of action is the same, so they're used to treat hypertension क्योंकि ये ज़्यादा longer acting हैं than thiazides. फिर आते हैं potassium sparing diuretics पे. ये aldosterone antagonist होते हैं and they act on the collecting tubules. अच्छा, अब ये दो तरीकों से act कर सकता है. इधर diagram पे show नहीं हुआ हुआ, मगर in the principal cells it has separate channels for sodium and potassium. तो जो amiloride है और triamterene है, वो ब्लॉक करता है सिर्फ सोडियम चैनल को और पोटेशियम को स्पेयर कर देता है, जिसकी वजह से रिटेंशन ऑफ पोटेशियम हो जाती है और सोडियम एक्सक्रीट हो जाता है. मगर जो स्पाइरोनोलैक्टोन है वो इनहिबिट करता है एल्डोस्टेरोन को, और आपको पता है कि एल्डोस्टेरोन इंक्रीजेस द एब्जॉर्प्शन ऑफ सोडियम. सो अगर एल्डोस्टेरोन ब्लॉक हो जाएगा तो देन सोडियम वोंट गेट एब्जॉर्ब्ड एंड इट लीड्स टू पोटेशियम रिटेंशन, which causes hyperkalemia as a side effect. तो इसके side effects में नजर आ रहा है कि aldosterone antagonist cause hyperkalemia, and one of the most important side effects that we get tested on is spironolactone causes gynecomastia in males and menstrual irregularities in females. Amiloride is also used in cystic fibrosis to improve the mucociliary clearance. This is also a very high yield point. Finally, we move on to osmotic diuretics. Osmotic diuretics का general function है, they directly interfere with osmosis. हमें पता है कि water follows from dilute to concentrated. हमेशा जो concentrated जगह होगी वहाँ पे water आएगा. So these osmotic diuretics, they increase the concentration of the tubular fluid और ना ये absorb होते हैं because these particles are not small enough to get absorbed, so they just stay in the tubular fluid और उसकी वजह से उसकी concentration increase होती है, जिसकी वजह से water follows and it gets excreted out. इसमें जो drugs हैं वो है mannitol, urea, glycerine और isosorbide. जो mannitol और urea, they are given intravenously, while glycerine and isosorbide are given orally. जो mannitol है वो cardiac failure में contraindicated है क्योंकि वो expand करती है ECF volume और उसकी वजह से heart पे load increase होता है. So it should not be given in cardiac failure. That was the end of our lecture. I hope you enjoyed this video. Like, share, and subscribe.